I'm going to resume the recording. All right, well, thank you all for being here. My name is Victoria Melendez, and I'm super excited to have you all here. We are going to do a deep dive into the impact of the Rural Health Transformation Fund on the Delta region. Just to orient ourselves around our webinar series, I wanted to draw attention to a few components. We are going to have a question and answer component at the end of our time together. Feel free to put questions in the chat. You're absolutely going to, I'm imagining, be excited about this content. You might have thoughts throughout. It could be hard to hold your questions to the very end. So feel free to throw them in the chat and I'll be monitoring that. A little bit of context. I'm Victoria Melendez from LISC, or Local Initiative Support Corporation. We are supporting the Delta Philanthropy Forum. And I'm going to share a couple of quick slides before introducing Dr. Shaverd and Mr. Derek Lewis. So I will share those now. So welcome to the Delta Investment Spotlight. A little bit about us is that we are the Delta Philanthropy Forum. There we go. What is DPF? We're a diverse membership of a membership network of philanthropy, community development, financial institutions, and investors focused on the Arkansas and Mississippi Delta. And what we do is we develop investment strategies to drive transformational and equitable impact in the Delta region. What's our approach? Well, we focus on three main areas: education, capacity building, and economic mobility. Today, our focus is going to be the economic mobility piece. And through that, we are going to welcome Dr. Lanita Shaverd, Pharm D. She is the CEO of Community Health Centers of Arkansas. And Mr. Derek Lewis II, he's the chair of the Arkansas Black Philanthropy Collaborative. We're going to have a sort of fireside chat for the next 20 minutes or so, where they're going to walk us through how does philanthropy need to be thinking about the Rural Health Transformation Fund. So without further ado, let me stop the sharing and take it away.
Well, thanks, Victoria. Again, I'm Derek Lewis. Also, I'm the chair of the work group, the Economic Mobility Work Group for DPF. So I want to thank my fellow members of that work group for allowing us to do this today, and those that are on the call. I don't have a lot of time, so I got to get the shenanigans out of the way. Dr. Shaverd, which I've known her probably 20 years now, so it's going to be Lanita and Derek over here talking to each other. So, but she is a jewel for Arkansas, particularly in the healthcare space. Um, there have been times she served under me, and there's been times I've served under her. So that's how our relationship has been. But we are brothers and sisters. She's my little sister, and when we thought about doing this, she was the first person I thought of. So, Lanita, thank you for joining us and always answering the call when I call on you, which is quite a bit. But here we are.
You're
Um,
more than welcome.
yeah, so we're gonna talk a little bit about the rural health transformation
Yeah.
in this process, and part of why we wanted to do this is as these dollars are coming into particularly Arkansas and Mississippi, how should philanthropy be thinking about this? What are the takeaways at the end of our conversation would have, which is really what we're trying to gain from this conversation, and how philanthropy should be at the table, helping, hopefully developing some processes and some safe spaces and some introductions to organizations who may not know about the fund. But I'd love to for folks to know a little bit more about you and your organization, the particular Community Health Centers of Arkansas, and why that organization is really important to this conversation.
Sure. So number one, thank you for having this fireside chat. I was looking for the fireside. I don't have it, but I do have my heater on next to me. So if you hear a heater in the background, it's mine because I'm always cold. But So, Community Health Centers of Arkansas is the state's primary care association. So, every state has a primary care association, and they were actually mandated by the federal government. And the role of those associations is to provide training, provide advocacy, which is a lot of the work that I do for federally qualified health centers in the state of Arkansas or whatever state you're in. So, in Arkansas, we have 12 FQHCs and one Louisiana-based FQHC that has come across the border. So I have 13 FQHCs that I spend my time doing everything that they need to support them to continue to see patients. So for those that don't know, FQHCs have some federal funding, but they basically are in areas where there is not a lot of medical access. And so their goal is to expand access for patients in the state that they're in. We see all patients regardless of their ability to pay. And so as you can imagine, in a state like Arkansas, we have patients that don't have a payer for their health care. So they don't have private insurance or Medicaid or Medicare, what have you. So we see all patients. So Medicare, Medicaid, private paid insurance patients, and then those patients that are what we call cash pay or don't have a payer for their health care. And so it is my privilege and honor to serve them as their association to do everything that we can to ensure that they have smooth operations across the state. And if I do say so myself, there are some pretty phenomenal primary care practices. I mean, you know, your father's a primary care practitioner, and so you know the things that come into a primary care doctor's office. And so the way that they handle those patients in the most destitute areas of our state is nothing short of a miracle.
Sure. About how many lives are you guys overseeing?
Great
Or
question. Perfect question. So in Arkansas, there are 3 million people. We're a pretty small state. We see about 13%. We see a little over now. The last numbers I got 2 weeks ago, 360,000 patients come through our doors in Arkansas.
patients are in the rural context?
Yes. And so we have a couple that are in urban areas, but the majority of them are in rural areas. So we have a couple in Little Rock, a couple in Northwest Arkansas, but mostly in the rural parts of the state.
I knew all these answers, but I needed to ground us and set us up. Um,
Absolutely.
because you're before even the rural health transformation came out, you were already doing this work, and so I think that leads us into, what is rural health transformation and what should we be thinking about individually as organization, collectively as
Yeah.
those who are advocating for healthcare for all.
Yeah, sure. So the interesting thing is I talk about rural health transformation all the time. I call it RHTP, Rural Health Transformation Program. But the funny thing is most people that are not in this space every day have no idea what this is and what it's about. So I'm glad you asked that question. So Rural Health Transformation Program came about as a part of the One Big Beautiful Bill. So I call it OB3 for short. And so OB3 set aside $50 billion for rural health transformation. And that is going to be distributed over 5 years' time. So 2026, so this year until 2030, so 5 years' time. They are, I mean, when I say they, the federal government is going to disperse $10 billion each year. So it's 5 years, $10 billion per year for those 5 years. What they have done though is 50% of that, so 25 billion was set aside to be dispersed to all states equally. So every state got kind of their, because you're a state, you get, part of this $25 billion. The other 25 billion though, the federal government mandated that the state's governor's offices put an application in for their piece of that 25 billion. And so they were given very specific things that they had to address in their proposal. So the proposals went out. So only basically the number of states or the only number of applications that the federal government received, which was probably smart to make sure you only have a finite number of applications. If you can imagine putting that out to everyone, that's probably overwhelming. And so the federal government asked that they look at and propose how they would, and I want to make sure I'm getting this right, how they would stabilize and sustain rural healthcare access, so rural healthcare, advanced care transformation and value-based care models. So basically payment based on value, not on just seeing a patient. And then the third thing was to strengthen system integration and community-based solutions. And so they had to clearly address each of those
But in the application or the notice of funding opportunity, it really pushed them towards plans that figured out how to make sure people have access, to make sure that they address workforce. They also had to address system transformation. So really, there was a hard focus on how are you going to transform healthcare in this proposal, and then also sustainability and innovation, which is another big focus of the Rural Health Transformation.
So that third piece, that community piece, and I think that's where I think our partners can
Mhm.
really think through how they can be ambassadors or amplifying sort of
Yeah,
this.
for
So
sure.
give me just two or three outcomes, if you will, what we're hoping for, particularly in the community space. We call it obviously in Arkansas, it's the Delta, where we're gonna there's gonna be a lot of focus, but just two or three things that outcomes that you think this program can help.
I think a couple things. Number one, sustainability. It must be sustainable. So this money is only there for 5 years. And once the 5 years is up, the federal government is looking for plans that are able to keep going once this money is gone. It's a finite amount of money and a finite amount of time. So things that will continue once this money's gone. I do think also innovation is going to be huge. Figuring out how, when I say innovation, not just don't just think technology, but how do we innovate how we see patients? What does that look like in a clinic setting? How do you bring healthcare closer to people without expanding, building more hospitals, building more clinics, and things of that sort? And so, how do you use technology to do that, and how do you innovate to do that? I will say, in the same vein of that, one of the things that this program will not pay for is infrastructure. So you can't say I'm going to go build a new fill in the blank. No, there's some small funding for already existing build outs or already existing renovations, but no new buildings. So it's how do you build out your plan where you can use technology to its fullest. And I think the third thing I would say is really partnership and integration into the community. Looking at who are the partners you need to bring in and how do you use those existing partnerships and community members to help expand your reach, basically. Those would be
Yeah,
the three things I would say are there.
thank you. I think that again, I'm just harping on staying on. I think that's where our philanthropic partners can be an asset because many organizations, particularly in the DPF format, are already working in the Delta and know those organizations, and hopefully can connect the dots on some of this. Um, Staying in the Delta, you know, you talked about there's no new infrastructure, but we also are seeing where hospitals are closing, um, which is an access issue.
Yeah.
Um, and hospitals close, and many of these hospitals are the economic hub for those communities. So I really would love you to talk about, the connection between healthcare and workforce, particularly where you see this conversion of workforce in healthcare, particularly in the Delta area, and hopefully what the rural health transformation can hopefully do some expansion of the workforce.
That's a tough question. And I'm just going to be real honest with you. And the reason it's tough is that it's particularly in the Delta area, across all the states that kind of border the Delta area. Workforce and healthcare are deeply connected. And when I say that, when the population declines, so we have populations that are declining 5 to 6% every decade. We have some populations that are declining more than that. So it's a little bit scary. But that means fewer workers, that means fewer patients. That means shrinking economic, base in those areas. And so when you don't have a strong healthcare workforce hub, you tend to lose a lot of the economic base in that area. The other thing is that we see a lot of workforce gaps. There's not a lot of training programs in rural areas. And so, if you have someone that may be interested in healthcare training, there may not be a place for them to go unless they go to Little Rock or Fayetteville, or they have to travel, and that may not be feasible for them. So, healthcare and workforce and economics are tied together in such a way that from my personal standpoint, it's becoming quite concerning. It has been concerning, but it's becoming more concerning because every time we see a census and populations declining 5 to 6%, it's going to just by basic math, not even the new math, not the core math, just basic math. 1 + 1 is 2. You're going to eventually get to 0. And so I think we do have an opportunity. I talked about kind of the declining populations, but in some of those rural areas, the healthcare workforce is really the economic driver. And so it may be in the hospital, it may be on the clinic side. And so as much as we can train and retain those people in rural areas to work in the healthcare space, we can try to keep some of that economic development, that economic hub in place. But that takes a lot of things that need to happen to keep them in that area. The other opportunity I see with when it comes to workforce in particular is, and many companies are now leaning into this now, and that's this kind of concept of grow your own. So if you have a lower level healthcare worker in your clinic, in your hospital, can you get them the training to move them to the next level and growing from the inside, if you will? Now, when you do that, you have to backfill those other positions. So you've got to reach into your high schools, reach into your 2-year colleges and bring those people along and show them viable careers in workforce. And so workforce in many rural areas is the biggest economic driver because there are not a lot of other places to work. There's not a lot of, other than the schools, there's not a lot of stores, there's not a lot of retail, there's not a lot of restaurants. So healthcare can be the economic driver in those rural areas.
As you were talking, there's another work group we have in DPF, which is our education group, educational workforce. So I'm seeing the connected dots. We know we have Jonesboro or K-State, and there's several community colleges on both sides, Mississippi and
Mhm.
Arkansas. So it may be some opportunities as we think about workforce pipeline, and particularly, and obviously our organ AMDPA. I'm throwing this out is the physicians, the dentists, and then the pharmacists. But what about the techs, nursing,
Yeah.
dental hygienists, and so sort of those ancillary workers are going to be very crucial,
Absolutely.
particularly as we move forward. So,
Right.
um,
And
when, yeah,
speaking
go
about
ahead.
that, Eric, there's another kind of subset, if you will, of lay healthcare workers that we're starting to see
Mhm.
a lot of, and that's community health workers.
Yeah,
And you think about that subset of people, they are lay people that are trained to basically be connectors to people that are in their community to the healthcare system, right? The healthcare system can be so large and so cumbersome to navigate, but community health workers in particular are a great pool of people to draw from because number one, they've expressed an interest in healthcare by being a community health worker, but they're a great pool to draw from to get them into the healthcare system at whatever level, whether that's some kind of technician, some kind of assistant or what have you. So we have to really think about who are the people that we have lining up in the pipeline, and they're a natural kind of maneuver into the mainstream workforce in healthcare.
yeah. Community health workers, doulas. I think there's going to probably be a
Absolutely.
new new section of workers that we hadn't even thought about just because of where demographics, baby boomers
Yep.
on the tail end,
Yeah.
technology and all those things. So I would agree with that.
Mhm.
Just got a few more minutes. I'm gonna just hop into this next
Mm.
question.
Okay.
So when this first came out, it was not a lot of information given. I think a lot of people put applications in, and then once Arkansas, Mississippi was approved, now there's a different application process. So I guess the question would be, what are you hearing? What's the approach and intent for the
Sure.
use of the funds,
Sure.
particularly for both states? What are you hearing sort of on the ground?
Yeah. So from Arkansas, they have been doing this kind of round robin community forum, I guess fireside chats with no fireside, but I mean, I always have an issue with the fireside. That's another conversation. But in Arkansas, and Arkansas kind of built a multi-component um, ecosystem, I guess, approach that I would say that involves the community. And it is really about long-term transformation. So I will say I'm in Arkansas, so I'm a little bit biased. I think our governor's office did a wonderful job on the proposal because it really looked at and pushed towards kind of that long-term sustainability. And so they really looked at kind of four different areas, and they laid their areas out better than some of the other states. And so what we're seeing is access and care coordination. And so things like making sure that people have transportation and there's mobile, healthcare, things of that sort. Prevention and social drivers. So looking at nutrition, looking at food as medicine. So really leaning into what we're seeing coming out of the federal government. Workforce development, which we've been talking about, and then also technology. So they really built kind of this coordinated system that is almost ground up as opposed to top down. Mississippi took a different approach. It's not wrong, but it is different. It's a more centralized approach that is more governor's office driven down. And so their approach is kind of the governor's leads the prioritization. So they determine this is what we want to do, this is what's fundable, this is what we want to make sure happens. They have targeted program investment in Mississippi. So that means they're looking for very specific, very high impact projects, and those are the ones they're going to fund. And then they have also these formal stakeholder engagements, which is interesting, but it's basically like an application style presentation that you do to go and talk about what you want to do with the funds. And then they are pairing you with a consultant that can help you through that process. And so theirs is more a centralized kind of governor's office leadership of it, and then doing targeted funding for basically looking at what has worked and expanding that. So two different thought processes. But honestly, Derek, whether you like one program or over the other, it doesn't matter. What's going to matter is how much they can make these programs work and what is sustainable and what is sustainable year over year. So the federal government is putting some pretty stiff reporting requirements on states to show, hey, these are our outcomes. This is how it's transforming healthcare in order to get that money the next year. So each state applied for the money for additional funding this year. They have to keep applying for it. And their application is really going to hinge on, and their success of the application is going to hinge on how well were your initiatives. And so whatever approach they take is really going to depend on how they make it come through.
Yeah. I'm gonna ask the question with the answer in mind as I think about the funders that are on here. It to me it would
Yeah,
make sense if our funders that are deep in the Delta area and have the relationships to actually be working on these applications together with some of these
yes.
organizations, even if it's just technical assistance. But I'm going to ask the question anyway. What should funders be paying attention to, as they align, and we can talk in line with strategy, but both states really with the two different perspectives. How
Mhm.
should funders be aligning with those strategies?
Sure. I think one of the things you said originally, making sure they're partnering, especially in Arkansas, there is a very strong, um, I don't know the word to use. It's a very strong urging to partner in Arkansas. Not as much in Mississippi, but in Arkansas, they're really urging partnerships. They're urging people come together regionally as well. And so looking at things that the funds don't cover, right? I think that's where philanthropy really can step in. The funds don't cover infrastructure. The funds don't cover barriers to getting healthcare, access to food, access to transportation. So looking at those things that you may partner with an organization that says, hey, we can fix this problem, but our patients still have this barrier. That's where funders, private funders, can lean into it. I think for smaller funders looking at supporting community initiatives that are working, community-based programs that are working, how can you help them be sustainable? I think for your kind of mid-sized funders, how can you help people scale and get to where they want to be? And I think the larger funders have a real opportunity to look at what is the infrastructure needed to make real change long term. And so I think basically partnership, figuring out how you can fill in the gaps that these funds don't pay for, but are very necessary, and making it work is going to be important. You know, as well as I know, in rural communities, it's really just one thing that prevents people from getting health care or really prevents people from thriving in life in general. So we've got to figure out what is that gap between healthcare and thriving and where patients are. And that's where funders, private funders can fill that gap.
Victoria's on is pop back on is to give us our
That
cue
means we
that
have to shut up.
and
Oh, thank you
she
for the fireside.
brought your fireside in. I'll just say thank you for this conversation. Obviously, you and I will be continuing this conversation in other settings, but I appreciate the time this afternoon.
Thank you for the invite. I appreciate the opportunity to just talk about it and hopefully explain some things that people didn't know.
All right, Victoria, I'm gonna shut up.
Wonderful. Thank you. I don't know if the fireside is still showing,
It
but
is.
since
It
we
is.
so I haven't gotten any questions in the chat. So y'all speak now, or forever hold your peace, please. But one question I had is, you know, if you had just one thing that you wish philanthropy knew about this intersection between, I guess, like health and finance and workforce and all that in the Delta, what is the thing you're just like, I just need philanthropy to understand this thing?
Just one thing, huh?
Yeah,
Um,
got to choose.
I know, right? There's so much left for me. So I think probably the most real thing I can think of is if healthcare doesn't work for the workforce in rural areas, then the workforce can't work,
Mm,
and at some point the economy dies. And so it's important. Health is, and when I say health, I mean overall health is important for a workforce to thrive, and you have to have a thriving workforce for those small communities to continue to be in existence. As
mm,
as members are dying out and you're not replacing people, we're losing communities, and it's abysmal. As a part of that, looking at not only physical health, what people are eating, what access they have to healthy foods, what access they have to activity, like the full health of a person. So we need healthy people in order for healthcare to thrive, in order for cities to thrive.
that
Hey, Victoria,
that is
I think chat may be disabled. That's why you may not be getting any
what?
questions.
How do
Uh,
I enable it?
QA is
so
on.
the QA is on. So if you have questions, you can just put it in the QA part.
Yeah.
Yeah, let's see.
And as you work that out, I don't think I would add to that is from a philanthropic standpoint. A lot of our organizations are already working in the Delta.
Mhm.
I think there's an opportunity. I think in the application process, with many of the organizations, particularly who are working either in healthcare or adjacent, because as you talk, it's transportation, it's education, it's economics. All these things impact health, and so I think you know, working as a in a technical standpoint could be very interesting,
Mhm. Mhm.
and also just being in the mix of the process of being at the table when decisions are made. These
Yes.
most of our organizations have some level of influence,
Mhm.
um, and hopefully they're utilizing that influence as these dollars are being distributed.
Mhm.
Hmm.
You know,
Well, I'm
that's a good point. I'm sorry, Victoria. That's a great
go
point.
ahead.
One of the things that we are seeing, there are some business opportunities that are set to come into South Arkansas very soon. But there are issues like, is there maternal health available? So you can't have a ton of people coming into town and they want to bring families and there's not maternal health available. Is there a good education system? So this is a really a chance to look at the total care system for people and what wraps around them and what they need to live, and it's going to take some tough conversations and tough decisions because you have to look at all of those parts. Healthcare is just one that we're talking about today, but you're very right. Education matters, housing matters. Where do you shop? Where do you know, people, younger people love to go out and be social. There's one restaurant, in Marianne or wherever. So you have to look at all of those. There's a larger infrastructure issue here that this does not cover by itself, but one of the things that we have to start looking at is how we close those gaps.
Hmm. Well, really quickly, because I see these questions now,
Mhm.
and I know we're over time, but I'm really sorry that the chat was disabled. I put everyone with the ability to come off mute, but I'm going to go through the questions, and if I can
Sure.
just have 2 more minutes. Keith Fulcher asked, he said, our community foundation has created a healthy food hub curriculum for food pantries as part of our food is medicine effort. So
Mhm.
less of a question, more of a comment, which we really appreciate. And
Definitely.
then an anonymous attendee asked, when you think about innovation on the ground in rural communities, what does that really look like, particularly around collaboration with philanthropy? Are there places you've seen doing this well? And how do you see community health workers playing a role in bridging patients to telehealth, especially where there are barriers around trust and technology?
I love both of those questions. So the first question about kind of philanthropy and some of these collaborations, there's a lot that can happen there. One place that it is actually working well is with some training programs. So we know everybody is not meant to go and get a PharmD or an MD or what have you, but there are training programs that philanthropy can really play a part in continuing to fund. Typically, training programs. So we have one that is run by the Rural Health Association, where they train medical assistants, they train EMTs. And so those kinds of training programs are helpful for areas where kids don't have to take out a student loan. It may be providing grants for kids to go to those training programs. So it's training programs and things like that that are working well. That's one example that I can think of just right off the top of my head. And then the second question about community health workers being that bridge to patients with telehealth. So I learned this when I came to Arkansas. People are mistrustful of telehealth. I don't know who's behind the camera. I don't know who else can see me. I don't know what's going on. And so community health workers can do a couple of things. Number one, they can be with the patient to help them set up that connection securely. They also can do some explanations about what this is going to look like. So that will help to get rid of some of those fears or quell some of those fears. This is what is going to happen during this visit. These are the kinds of things that you are going to need to be able to do. But they can also help the patient prepare themselves for it. Make sure that they have a good screen that's clear. Make sure they have a good connection. All of those things. One of the things that community health workers I have seen them do a great job with is explaining processes to patients. Many times when patients come to see me, I tell them a whole bunch of stuff and they don't remember half of what I said. But a community health worker can sit down with them and explain some things that are non-medical to them to help them understand what's going on. And so they are actually a great liaison with patients when it comes to telehealth. We use them in our FQHCs to help with that. And sometimes it's as simple as them getting the patient to the nearest stable environment to have that conversation. So the patient's home Wi-Fi may not work that well, but we can get them to a library in a private room or somewhere they can have that conversation. And so that works really, really well for medical purposes, excuse me.
One
Wow,
thing I
that
would
is
add to
so
that
powerful.
is one thing I'd add to that. I think there's going to have to be a multi-tier approach to this. So you're going to have your community health workers, your local nonprofits, but there has to be some engagement with your city council and mayors because as that money comes in
Absolutely.
into these communities, they're going to know who those organizations are,
Mhm. Mhm.
and they're going to know the process of sort of you're going to have some champions along the way in these communities to do this. And I think, your mayor, your city council, your pastors and your faith-based community, and others are going to need to be a part of this process and working alongside the philanthropic agency. So,
One of the things in Arkansas that's written into our proposal that I think was brilliant is the faith-based community. And so many times patients will go to their pastor with their medical questions before their provider. You know this, Derek. But that's important to give that liaison and that bridge to it. And so including the faith-based community in the Arkansas proposal was pretty ingenious.
Well, that's wonderful. Thank you so much for being here. I know we're a bit over time. And again, apologies for those who were not able to contribute to the chat. If you have additional questions, you can email me and I will
Mhm.
happily forward them along to Dr. Shaverd.
Yeah.
But thank you for being here. This was so great. And I hope you all found it to be a fruitful time. The goal of this time together is that we can demystify how we can collaborate in the Delta to enact change. And the intersection between health and workforce is one that we don't talk about enough in this world. And it's literally everything because you kind of have to be healthy if you're gonna have a job. Those
And I
kind
have
of
to
work
be.
together just a little bit. Um, so thank you all for being here. If you haven't signed up yet, the same link that you used to register for today is the same link you can use to register for next time, which is June 8th of this year. We have these little conversations every other month, and each one is a different focus on an issue area in the Delta. So thank you for being here, and thank you both, Dr. Shaverd and Derek, for taking the time of your busy schedules to present to us. We hope you have a great rest of your day. Thanks,
Thank
everyone.
you. Thanks so much.
All
Good
right,
one.
bye.